Good day. Very quick topic. We're going to tackle hemoptysis. My reference, as always, is Tintinalli's Emergency Medicine. Hemoptysis is the expectoration of blood from the lungs or tracheobronchial tree. Severity ranges from mild to severe, and it can be difficult to stop. The challenge is to stabilize the patient while simultaneously determining the source and providing treatment. Most cases of hemoptysis are mild and resolve spontaneously, but predicting which individual will develop large volume bleeding is difficult. Assessing the amount of expectorated blood is difficult because patients may either exaggerate or be unable to quantify the amount. The definition of massive or severe hemoptysis varies, with reported ranges from 100 milliliters per 24 hours to more than 1,000 milliliters per 24 hours, with a midpoint value of 600 milliliters per 24 hours accepted by many. However, because even small volumes of blood can cause asphyxiation, any hemoptysis requires prompt attention. Morbidity and mortality depend on the rate of bleeding, the ability of the patient to clear the blood, and the presence of underlying lung disease, which potentiates the effects of blood in the airways. We define minor hemoptysis as small volume expectoration of blood in a patient with no comorbid lung disease, normal or stable oxygenation and ventilation, normal vital signs, and no risk factors for continued bleeding. Hemoptysis results from disruption of blood vessels within the walls of the airways, from the trachea to the bronchi, bronchioles, and the lung parenchyma. The pulmonary arteries account for 99% of arterial blood flow to the lungs, but are a low-pressure system and rarely are the source of hemoptysis. So causes of hemoptysis include infectious, which may be acute bronchitis, tuberculosis, lung parasites such as paragoniasis, echinococcus or schistosomiasis, mycetoma in the case of aspergilloma, and may be structural, such as in bronchiectasis, caused by cystic fibrosis, organizing pneumonia or chronic bronchitis, tracheoarterial fistula in the case of a tracheostomy, aortobronchial fistula in the case of aortic aneurysm erosion, and hypersensitivity pneumonitis in occupational exposure. Vasculitis such as Goodpasture syndrome, also known as antiglomerular basement membrane disease, may also cause hemoptysis. So can granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis, systemic lupus erythematosus, and Behçet's syndrome. Cardiovascular causes of hemoptysis include pulmonary embolism with infarction, pulmonary hypertension either through mitral stenosis, congestive heart failure, or left-sided endocarditis, neoplastic causes such as bronchogenic carcinoma and bronchial adenoma, iatrogenic causes such as bronchoscopy, lung biopsy, and pulmonary artery catheter injury, traumatic such as a ruptured bronchus from deceleration injury, lung contusion from blunt injury, penetrating trauma, or miscellaneous such as nitrogen dioxide inhalation, cocaine inhalation, and catamenial or pulmonary endometriosis. Wow, that's really unfortunate. The bronchial circulation accounts for only 1% of the arterial blood flow to the lungs, but 90% of the cases of hemoptysis because it is a high pressure system. The bronchial arteries typically branch off the thoracic aorta and are responsible for supplying oxygenated blood to the bronchi, pulmonary arteries and veins, and lung parenchyma. They follow the course of bronchi along their tortuous paths. Once the bronchial arteries reach the level of capillaries, three anastomoses occur. The larger bronchial arteries can merge directly with the alveolar microvasculature. The smaller bronchial arteries can merge with the veins of the pleural and pulmonary drainage system, and bronchial capillaries can merge directly with pulmonary capillaries. These connections produce a physiological right-to-left shunt comprising 5% of the total cardiac output. So just to recap, pulmonary arteries account for 99% of arterial blood flow, but they're low pressure, but the bronchial circulation accounts for 1% of arterial blood flow, but 90% of the cases of hemoptysis because it is a high pressure system. Many inflammatory and infectious processes can lead to hemoptysis. Coughing in the setting of transient airway inflammation, such as acute bronchitis, can lead to minor bleeding even in otherwise healthy lungs. In chronic inflammatory states like tuberculosis, cystic fibrosis, or chronic obstructive pulmonary disease, the bronchial arteries can proliferate and enlarge to enhance the delivery of blood to the alveoli. Such neoangiogenesis creates thin-walled, fragile vessels prone to rupture. Chronic disease states can lead to bronchiectasis or chronic bronchial wall inflammation, resulting in dilatation and destruction of the cartilaginous support, predisposing blood vessels to rupture. In the case of Aspergillus infection, there can be necrotic destruction of tissue, but more often there is a colonization of a previous area of pulmonary decay, resulting in cavitary fungal balls. Neoangiogenesis from bronchial artery branches occurs in cavity walls. A Rasmussen's aneurysm is a false aneurysm of dilated tortuous branches of pulmonary arteries crossing the wall of a tuberculosis cavity. Although tumors can directly invade the bronchial and pulmonary arteries, they also promote neoangiogenesis. In particular, squamous cell carcinoma accounts for a large number of cases of massive hemoptysis. Traumatic cases of hemoptysis include deceleration injuries and penetrating trauma to the chest. Iatrogenic causes include direct arterial injury by pulmonary artery catheterization or biopsy of lung tissue during bronchoscopy. Biopsy of a carcinoid tumor can be associated with impressive hemoptysis. Hemoptysis secondary to fistulae between an aortic aneurysm or aortic inflammation and its primary branches can precipitate catastrophic hemoptysis. Tracheoinnominate fistulae result from erosion of a tracheostomy into the innominate artery that courses posterior to the upper sternum. Arteriovenous fistulas forming between the low-pressure pulmonary arteries and pulmonary veins have thin walls that are easily ruptured. Osler-Weber-Rendu disease is associated with hemorrhagic telangiectasias of pulmonary arteriovenous fistulas, as well as telangiectasias of the skin or mucous membranes. Cardiac disease processes that elevate pulmonary pressure, such as mitral stenosis and congenital heart disease, can trigger hemoptysis. Distal pulmonary embolism can lead to infarction of lung tissue that results in edema and hemorrhage, which can be exacerbated by the use of anticoagulants. Vasculitis and collagen vascular diseases such as Goodpasture syndrome, systemic lupus erythematosus, and granulomatosis with polyangiitis damage the lung parenchyma, predisposing to alveolar hemorrhage. Anemia can result from chronic diffuse alveolar hemorrhage. The cause of hemoptysis in up to 30% of cases is undetermined. Expectorated blood is bright colored if the source is the upper airway or lungs. If hemoptysis resolves prior to evaluation in the emergency room, history is then paramount for evaluation. Patients give an accurate history regarding the source of bleeding about half the time. We ask for risk factors for hemoptysis, such as smoking, which predisposes to chronic lung inflammation and vascular disruption and increases the risk of bronchiogenic carcinoma. Tuberculosis is a leading cause of hemoptysis worldwide, so we also ask about a history of tuberculosis. Patients with previous venous thrombotic disease may have a pulmonary embolism as a cause. We ask about hematuria or known renal insufficiency given the link to Goodpasture syndrome. Individuals with the connective tissue disease or suggestive symptoms such as arthralgias, myalgias, recurrent fevers, or rash may develop vasculitis and hemoptysis. Granulomatosis with polyangiitis is a more insidious vasculitis. We look for the saddle nose deformity from septal perforation. The lung fluke, also known as paragonomus, infects humans after eating infected crab and crayfish and can cause hemoptysis and chronic infection. The tapeworm, or echinococcus, can lead to hydatid cysts within the lungs. Cyclical hemoptysis coordinating with a woman's menstrual cycle could indicate a catamenial source from pulmonary endometriosis. Cocaine and heroin inhalation can trigger diffuse alveolar hemorrhage. Nitrogen dioxide exposure in indoor ice arenas may also cause hemoptysis. We also ask about the use of anticoagulants in recent procedures such as a Swan-Ganz catheter insertion and bronchoscopy. So just to give a quick recap, causes of hemoptysis may either be infectious, structural, vascular-derived,
cardiovascular, neoplastic, iatrogenic, traumatic, or miscellaneous, such as inhalation of chemicals like nitrogen dioxide and cocaine. Also, this category also includes pulmonary endometriosis. So, just for consolidation's sake, pulmonary arteries are a low pressure system. They account for 99% of arterial blood flow, while bronchial circulation accounts for 1% of arterial blood flow but 90% of hemoptysis cases because of the high pressure in this area. On physical examination, we examine the sputum to see if it is just blood streaked or contains clots of blood. Generally speaking, patients often bring a sample of sputum, which helps assessment. We also look for signs suggestive of major hemoptysis or underlying lung disease such as tachypnea, tachycardia, hypotension, labored respirations, and hypoxemia. If airway, breathing, and circulation are maintained, we focus on the physical exam. We evaluate the nares and posterior pharynx for evidence of epistaxis. Then we assess airway patency and potential difficulty of intubation. We auscultate the lungs for any wheezings suggesting airway inflammation or focally reduced breath sounds indicating a location of bleeding. Occasionally, crackles may be present suggesting diffuse alveolar hemorrhage or heart failure. On a cardiac exam, we auscultate for murmurs of valvular disease. We check for telangiectasias and petechiae on the skin exam. Most patients with minor hemoptysis need no specific tests unless they are on anticoagulation medication. For patients with massive hemoptysis or recurring hemoptysis, we obtain a metabolic assessment including electrolytes and renal function studies, CBC, coagulation studies, and urinalysis. Baseline hemoglobin concentration is often falsely elevated in acute rapid bleeding, as equilibration may not occur for 6 hours. Thrombocytopenia and coagulopathy increase recurrence risk and morbidity from hemoptysis. Urinalysis and renal function tests help narrow the differential diagnosis, which includes Goodpasture syndrome and granulomatosis with polyangiitis, and can also identify those at risk for contrast nephropathy if imaging is contemplated. Chest X-ray is the initial imaging modality and yields a diagnosis of up to 50% of the time, and in massive hemoptysis, X-ray is rarely normal. Diffuse alveolar hemorrhage manifests as scattered alveolar infiltrates on chest X-ray, whereas infiltrates, atelectasis, masses, and cavitation are localized as potential sources of hemoptysis. Multi-detector Rose CT delineates abnormal bronchial and non-bronchial arteries using reformative images while limiting scan time and respiratory motion artifacts. It can also identify bleeding from a pulmonary artery, as in Rasmussen's aneurysm, or from an anomalous vessel, as in Guilleaume-Foy's disease, a tortuous dysplastic artery within the submucosa. Bronchial arterial bleeding is almost always detected on multi-detector Rose CT, whereas non-bronchial arterial sources can be identified more than half the time. Multi-detector Rose CT is preferred over CT angiography. However, the limitation of this evaluation for hemoptysis is that areas of bleeding can appear similar to infiltrate and tumor, and active bleeding can obscure a mass within the parenchyma. Hemoptysis promotes anxiety in the patient and their family members, so the goal is to identify the cause, reassure those with minor features and no threat of imminent harm, and provide an appropriate disposition. The amount of blood expectorated, respiratory status, and risk factors for continued bleeding dictate the disposition. So patients with mild hemoptysis can be assessed first through history and physical examination, and if it is determined to be minor or mild hemoptysis, we go for chest X-ray. If chest X-ray yields positive, we do not suspect acute bronchitis. We go for CBC, renal tests, urinalysis, and coagulation factors. And then we look for follow-up pulmonology if these tests have anything that is significant. If the chest X-ray is negative, we suspect acute bronchitis, and then the patient can then follow up from their primary care physician. Most cases of hemoptysis are mild and self-limited. For mild hemoptysis, we arrange follow-up with either the primary care physician, an otolaryngologist, or pulmonologist. However, pulmonologists are obviously preferred if the patient has lung cancer or they have structural disease. If a patient has an acute bronchitis, we treat them with the appropriate antibiotic. Treatment for severe hemoptysis requires airway control and emergency bronchoscopy and often requires consultation with cardiothoracic surgery and interventional radiology. So, in patients with more severe bleeding, we assess and ensure that the airway is patent and check for ongoing oxygenation. If the patient has a tracheostomy, we look for a trachea innominate fistula, which can be controlled with direct digital pressure on the anterior portion of the trachea against the posterior aspect of the sternum, using the tracheostomy as the point of access. If the patient does not have a tracheostomy and requires airway control, we proceed immediately with rapid sequence intubation, allowing for bronchoscopy with a larger diameter endotracheal tube. Once intubation is successful, we place the patient so the affected lung is in a dependent position to prevent spilling of blood into the unaffected side. If bleeding is uncontrollable, you may preferentially intubate the main bronchus of the unaffected lung, and alternatively, to stop bleeding, some use a Fogarty catheter to tamponade the bronchus of the affected lung. The latter can be accomplished by passing the Fogarty catheter adjacent to the endotracheal tube once the patient is intubated. If attempts at intubation fail, cricothyrotomy is an option. Once the airway is stabilized, we restore volume with crystalloids and transfusion of blood products to correct for anemia and coagulopathy as indicated. Urgent bronchoscopy is needed in massive hemoptysis to identify the origin of bleeding and provide stabilizing treatment. Bronchoscopy may be performed by a consultant if the patient is unstable. Awake, flexible fiber optic bronchoscopy provides visualization of the more peripheral and upper lobes but does not provide optimal suctioning and does not allow for local treatment. Rigid bronchoscopy usually requires general anesthesia but can be performed with deep sedation in skilled hands. Rigid bronchoscopy cannot fully view the upper lobes and peripheral lesions, but it offers greater suctioning ability than fiber optic bronchoscopy and can provide treatment such as the passage of a Fogarty balloon catheter for tamponade of bleeding, epinephrine instillation, and ice water lavage. After rigid bronchoscopy, a flexible bronchoscope can be passed down the lumen of a rigid bronchoscope for more detailed inspection. Definitive bleeding control may involve cardiothoracic surgery or interventional radiology. Emergency surgery is often reserved for massive hemoptysis resulting from leaking aortic aneurysm, iatrogenic pulmonary artery injury, thoracic trauma, or bleeding from a tracheo-innominate artery fistula at the tracheostomy site. In other causes of hemoptysis, or if the cause is uncertain, bronchial artery embolization is a common treatment of massive and recurrent hemoptysis. Even in cases of mycetoma from aspergillosis, adenoma, hydatid cysts, and active tuberculosis, where surgery is still indicated as the ultimate treatment, embolization can temporize bleeding and stabilize patients for elective surgery. Risks of bronchial artery embolization include transverse myelitis due to spinal cord ischemia and pulmonary artery infarction from spread of embolic material beyond its intended site. So, in massive hemoptysis, we of course check if the patient is stable first. If they are, we request for a chest x-ray and labs, check for renal function, and if renal function is abnormal, we do CT without contrast and then see if the patient needs surgery. If renal function is normal, then we do multi-detector computed tomography, and if that turns out positive, the patient might need intervention radiology and cardiothoracic surgery consult. And if the patient is negative for multi-detector computed tomography, they may need to be admitted to the ICU. For patients who are not stable, we immediately consult intervention radiology and cardiothoracic surgery. Bronchoscopy is performed, and if the patient is stable, then multi-detector CT scan is performed. And generally speaking, if the multi-detector computed tomography turns out positive, intervention radiology is called for bronchial artery embolization. If the patient is unstable after bronchoscopy, then surgery is indicated. So there are examples of techniques to control bleeding from the left lung. The first one is selective right main bronchus intubation for left-sided massive hemoptysis. And then another one is using a Fogarty catheter to direct control of hemoptysis coming from the affected lung, in which the catheter is passed by the endotracheal tube to preferentially tamponade the affected lung. And for a very quick consolidation, hemoptysis is the expectoration of blood from the lungs or tracheobronchial tree. It could be mild or severe. If it's mild, it's generally self-limited and we just give supportive care. If it is more severe, surgery or intervention radiology may have to be called. Causes of hemoptysis include infectious, structural, vascular, cardiovascular, neoplastic, iatrogenic, traumatic, and miscellaneous, which is basically chemical inhalation or pulmonary endometriosis. So, hemoptysis occurs from the high pressure system, that is the bronchial circulation, in comparison to the pulmonary arteries, uh, which have 99% of arterial blood flow but are low pressure. So, we ask for the patient's history, and risk factors for hemoptysis include smoking, chronic lung inflammation, carcinoma in general, especially bronchogenic, tuberculosis as well, renal insufficiency given the link to Goodpasture syndrome, and also any infections like paragonemus or echinococcus. The sputum is also examined. We check if the sputum is just blood streaked or contains clots of blood. Imaging is usually chest x-ray or multi-detector row CT. And if the patient has more severe hemoptysis, bronchoscopy may be indicated. Bleeding control can be done either through a Fogarty catheter or it could be done through a endotracheal tube with the cuff inflated. And that should be it.